healthcare professionals and patients. We have the pleasure to have with us three distinguished colleagues from around the world who will be presenting and elaborating on e-health and mobile applications. Professor Manuela Eicher, which is an associate professor of oncology at the University of Lausanne and director of the Institute for Nursing Science at the University of Lausanne and current president of the Swiss Oncology Nursing Society, will be presenting on the challenges and opportunities provided by the technological solutions for cancer care. Dr. Theologia Tsitsi will be presenting on utilizing the mobile application Prolipsis in the preventive context of breast cancer. Dr. Theologia Tsitsi is a special scientific staff at the university, at the Cyprus University of Technology, and member of the advocacy group of the European Oncology Nursing Society. Last but not least, Dr. Corina van der Hoek will be presenting on utilizing technology to manage symptoms. Corina is a researcher in the Netherlands Comprehensive Cancer Organization and co-chair of the Oncodermatology Study Group at MASC. And at this point, I would like to invite our distinguished speakers to provide their presentations. Thank you, everyone, and enjoy the presentations.
Hello, everyone. I'm really pleased to be invited to this satellite symposium, and I will share my screen to show my slides now. So during the next 25 minutes, I will talk about the challenges and opportunities provided by technological solutions for cancer care. And again, I'm really pleased to be with you today. So here are my declaration of interests that I want to share with you. And I would like to start my talk with an introduction of digital health or technological solutions in cancer care, looking at it more broadly. And I think the document that WHO provided last year on the global strategy for digital health gives us a nice introduction in what we are talking about if we are talking about technologies, not only in cancer care, but globally. And so what we can say is that the transformation with the digital solutions that are used and provided today are certainly disruptive in many settings. We are talking about technologies such as the Internet of Things, virtual care, remote monitoring, artificial intelligence, big data analytics, and I will come back to this, but also blockchain, smart wearables, platforms, tools, and so on. So this is included in this definition. The hope is that this will enable more data exchange, better storage of data, and also remote data capturing that would allow us to share relevant information across the whole health ecosystem. And again, the hope is that this would create a continuum of care, and we already have evidence that technology might provide the potential to enhance health outcomes by improving the diagnosis, but also evidence-based or data-based treatment decisions. Digital therapeutics also enable better clinical trials, but also self-management and person-centered care, and overall creating a more evidence-based knowledge, skills, and competence for professionals in healthcare. So in my talk, I will focus on 3 domains now to illustrate what we hope, but what are also the challenges related to the digital and technological solutions. So we'll focus a little bit on telenursing and telehealth. We'll then focus on artificial intelligence and also virtual reality. So if we talk about telehealth, one of my interests in research is focusing on digital health applications. And I can only recommend you the reading of the Opportunities and Challenges for using digital health applications in oncology that were discussed in a workshop and published this year. I use this graph from Ethan Bash that illustrates nicely what we hope could be established in different health systems in the future, is already working in some health systems. Is that we would have a patient portal that would allow us to remind patients to monitor their symptoms, their problems, all the things that they can report on their own via an electronic patient-reported outcome system that goes directly to the electronic health record, provides alerts and reports to nurses and oncologists, maybe other healthcare providers. But since this is a nursing session, we focus here particularly on the nurse, that might enable better symptom management. And we will hear more about this from Corina later in this symposium, providing telephone counseling, supportive medication referrals. On the other hand, the oncologist, besides providing also medication for supportive care and refer the patient, might also decide to modify the cancer therapy dose. So this is the whole system that could be based on electronic patient-reported outcome systems, and that looks very promising at the moment. So if we look more globally into the nurse's perspective regarding such telehealth and telenursing interventions, we can see that there are a lot of facilitators that could help to include such systems into units or even hospitals or health systems. Very important elements, and I illustrate this with some evidence, is the training, but also guidelines that are provided to the healthcare professionals, in our case here, the nurses. So I share with you a graph of a publication of 2020 already of McCartney and colleagues that were investigating priorities, barriers as facilitators for remote support of cancer symptoms. And they, in fact, illustrate here, on the one hand, the nurses' confidence for remote symptom management, and on the other hand, the frequency of the symptoms. And it's interesting that some of the frequent symptoms, like anxiety, the nurses' confidence to manage them was not so high. So it might be that we should provide them with better guidelines and training also to feel comfortable with that. Then other facilitators were integration of the electronic health record and in-person visit, quality infrastructure regarding the hard and software. We'll come back to that, and the ability to have live video chats. So if we look at the quotes that we find in qualitative research on this subject, nurses, for instance, really like to see the face of the patient. This is why I highlighted here the video chat. So they feel that the quality of the consultation is different if they can, if they have this interface and can see him or her. On the other hand, the nurses reported that access to the electronic health record is really very important, so that this is really connected, and electronic documentation, including symptom guidelines, would be very appreciated or facilitate such applications. And even if there were technological limitations, they also learn to assess a range of clinical features if they are trained and provided with sufficiently supportive infrastructure to use such tools. And we also see in this report that even if nurses identify problems and faults, they also find solutions. So it's also a question of a learning infrastructure. On the other hand, if we look at the challenges, so the technology literacy, so how familiar are people with using technology is a main challenge, and the technical incompatibility. So coming from Switzerland, I can sing a song about the interoperability of different systems. I will come back to this, but if the technological solution is not allowing a connectedness between different tools, this becomes very burdensome. And the exclusive virtual presence is considered as being a major barrier, as illustrated here in this quote, where the nurses clearly said if they don't have the ability to touch the patient, they do not feel comfortable in providing teleconsultations. And they also described constraints in relation to the direct effect of lack of their touch to the clinical present, but also a more broader, more impact on therapeutic elements of nursing care or the nursing role. But they also try to find solutions, for instance, use physically proximal third parties. So if other nurses would be close to the patient, to use them also as an information provider and exchange. But this remains a challenging question that we should further investigate. And of course, the security, the confidentiality of the data is a major threat as well. So I can just share experiences of a project that we are running in Lausanne at the moment at the University Hospital with one of my doctoral students, André Manuel da Silva Lopez, who will present details of this study in the EONS session on digital innovations in health. And I show this slide also to illustrate the challenges that we were confronted with. So the idea that we had was to develop an e-based electronically measured patient-reported outcome monitoring tool for patients under immune checkpoint inhibitor treatment, and develop a model of care that is based on this electronic monitoring. But it started already with the monitoring. So we had to do a Delphi round first to make sure that the pros, the patient-reported outcomes that we measure in this tool, really guarantee the safety of the patient. So for immune checkpoint inhibitors, we have another profile of toxicity. So we had to define in a European Delphi round which pros we want to measure, and we also have a poster at this ESMO conference. So if you're interested in this, I invite you to check this further. But we also had to develop the whole model of care. So it means, how does the nurse interact with the patient? How does the nurse then interact with the rest of the healthcare providers? And how does she triage the patients to decide if the patient should be seen immediately, should be seen by whom, and how do we make sure that all this information is also embedded within our electronic health record, because the tool and our health record are at the moment not interacting already. So just to highlight some of the challenges that are realized in research and might be even become more complicated if we go to clinical practice. I come to the second part of my presentation, which focuses on artificial intelligence. I wanted mainly to give you a little bit more in details on what are we talking about if we talk about artificial intelligence. So we talk about big data, about algorithms, machine learning, that artificial intelligence is based on. And if we look at big data today, what we can observe is that we have a whole different systems, technological solutions that enable us to collect big data sets. This goes via connected devices, the electronic health record, but also medical exams, but then can also be used and analyzed to support precision oncology, means to target specific populations or to target specific treatments in a specific population. So this is an incredibly large amount of data that would overwhelm our conventional statistical analysis methods. So what do? Is we try to develop algorithms that allow us to divide the data between relevant and not relevant data, so that we only include in our analysis the relevant data that is relevant to answer our question. But all depends, of course, also on the question and the quality of the data that we use for this. And then we can base on these algorithms machine learning, because we can train the machine to learn how to decide if the data is relevant or not relevant, to be able to treat this huge amount of data sets. And this can then allow the machine to artificially provide solutions to our questions or answers to our questions. But how powerful such algorithms are and how powerful and useful the answer to our question is will always depend on the nature of the data that are used and the way we create these data. And the artificial intelligence are often very vulnerable to biases related to that data. And so it means that we have a lot of responsibility when we develop artificial intelligence, and should always keep in mind to really question this point. So what is the artificial intelligence algorithm based on, and what decisions have been taken to that might influence the final result of this analysis. This is a reason why the European Commission published a white paper on artificial intelligence that gives a, I think, very good framework on all the standards that should be respected when artificial intelligence is applied. And I think for nurses it's very important to know these standards, and also if they are involved in projects, to question if these standards are really respected. So it means standard relating to the data, so they must really be valid, reliable. Standards relating to the record keeping, so is the databases really safe, and standards related to the transparency. There must always be provided clear information what are the capabilities of this and artificial intelligence system, but also its limitations, which goals they have, the conditions under which they are used and operated, and what's their level of accuracy. And EU citizens should always be informed that they are interacting with artificial intelligence instead of a human being, if this is the case. The standards also should guarantee the robustness of the artificial intelligence that is used and its accuracy, and that there is always an appropriate human oversight in all phases of the development and the operation. So this brings me to the third part of my presentation, which is focusing on virtual reality. And virtual reality, we will hear more about this also in our satellite, but it's an experience that is mentally or physically perceived as real, even though it's artificial, and this based on software or hardware. So you can see here an example of artificial intelligence, but why is this relevant for care? So it might enable a full immersion in simulated interactive settings, but in nursing care, this means that we can provide nurses with a learning opportunity, keeping them and the patients completely safe by simulating a situation that they might need to learn or be trained on. For patients, it might also enable them to learn about their health and also about their care, but also distract them from interventions that might be burdensome, painful, stressful for them. And I will bring some examples on this. Does it work? So for the education, we know from a systematic review and meta-analysis that evaluated the effectiveness of digital health education tools, that globally the trend is going into a good direction. So all the studies that were included in this meta-analysis showed that there was a trend in favor of a virtual reality supported education. If we go to the patient side and we look at the effectiveness of patient intervention with virtual reality, I brought you two examples here from pediatric patients with from hemato-oncology units. So here in this first study, they could show an effect on the maximum pain level, and also the time of thinking about pain, and also on positive emotions. Another study that investigated the effectiveness of a virtual reality distraction tool also during painful procedures could also show that even if pre-procedure the distress, but also the question how I feel did not show any significant differences between the two groups. We can see that during the procedure and after, during the procedure, this the virtual reality group had much better results. These are, of course, early investigations, need to be confirmed further, but show that there might be potential in using such tools. I brought you here some examples from pediatric oncology, but we will see others during this conference. So virtual reality can assist nurses during their training and education, and the effectiveness of the education methods should be investigated further. It might allow nurses to immerse themselves in diverse and complex situations to better understand how their patients experience everyday life. It facilitates patients' abstraction from care. So for patients, there might be a benefit, allowing them to better withstand invasive or potentially painful or burdensome interventions. And it might also enable patients to learn more about their health, disease, and treatment. So because we can simulate these aspects, and also maybe their impact on activities of daily living. So this brings me to my conclusion. What we can see in the literature, what I also see in my own work environment, is that a lot of nurses are still a little bit reluctant to these technological solutions because, I mean, the direct interaction between human beings, the emotional support, also the physical closeness to the patient is at the heart of the nursing profession. What I wanted to illustrate is that there might be some potential in having the opportunity to use technologies to support nursing care. I think it could never be a replacement, but we could probably, by providing more research and testing this in real world environments, we could really contribute to the development of such tools in the best interest for nurses, but also for our patients and their relatives. So we should really advocate for the public and patient involvement in the development of these technologies. And this is why I also set a highlight on the standards that we try to politically pose on a European level, to make sure that these are developed under the best ethical standards and always in the best interest of our patients. Thank you so much for your attention, and I'm looking forward to the question and answer session.
Good morning, everyone. First, let me introduce myself. My name is Theologia Tsitsi, and I'm delighted to be here today to talk to you about Prolipsis project that aims to develop a mobile application to promote healthcare promotion and breast cancer screening in informal cares. There is no conflict of interest to declare. My presentation is divided into 6 parts. I will start with an introduction of the subject. Then I will continue with the aim and objectives of the project. And finally, I will describe the 4 intellectual outputs of the project. The outcome of breast cancer treatment depends on the timing of its detection. However, women's adherence to screening programs is relatively poor, with the average attendance in the European Union being below 70%. Caregiving of a person with a chronic disease can be a contributing factor to poor screening adherence. Women who assume the role of the informal carer face additional challenges in engaging in health promotion practices such as breast cancer screening. The aim of the project is to develop a mobile phone-based health intervention as a means to enhance preventive healthcare behavior among informal carers population. The specific objectives of the project are to create a methodology and the relevant content extending informal carers' knowledge regarding the impact of their prevention avoidance behavior on breast cancer development, to educate and enhancing informal carers to assume control over this disease through adopting and maintaining changes in their lifestyles and living practices, to develop a personalized mobile application which will support informal carers to better manage self-care and behavior change in illness prevention. And finally, to produce a handbook for educators working with informal and formal education and healthcare professionals working with women's health promotion on how to use the app in health literacy reinforcement programs, targeting not only informal carers, but women's health in general. Let's now turn into the first intellectual output of the project. Here it should be emphasized that Prolipsis Consortium, supported by the firm belief that education and a tailor-made methodology can prove to be a positive experience that help carers' lifestyles and living practices. So before the development of the training program, we conducted focus groups with informal carers and professionals with the aim to setting the scene for the development of the educational program and other tools for women caregivers. So, the aim of the focus group with informal carers was to investigate their knowledge of breast cancer, screening guidelines, recommended practices, and their attitudes about the importance of screening for early detection of breast cancer symptoms. The aim of the focus group with professionals was to gather health professionals' community's opinions and describe their views on the educational priorities about breast cancer and breast cancer prevention, including screening. For example, gaps in their knowledge, their concerns, and priorities. Let's see the focus group methodology. Following informed consent 8 focus groups were organized by the member of the Prolapse Partnership. 5 focus groups consisted of informal carers and 3 of healthcare professionals and were organized in Portugal, Italy, and Cyprus. Specifically, 26 informal carers and 18 health professionals participated in this research. Let's have a look to the demographics of the participants. Informal carers were recruited from Cyprus, 9 in total, Italy, 5 participants, and 12 in Portugal. Mean age in the 3 countries was 57.72 years of age, and the educational level, the highest educational level, was recorded in Portugal, followed by higher secondary education in Cyprus and Italy. And we continue with the results from the focus groups regarding the informal carers' perspectives on the needs, attitudes, knowledge, beliefs, and perceptions of breast cancer prevention. Let's start with the knowledge. Participants reported to have knowledge of breast cancer prevention practices, including breast self-examination and clinical examination. They also recognized the value of screening tests, especially mammography, but not all of them follow the prevention programs, and often the sense of responsibility strictly connected to the role and the lack of the time of the carers. Unfortunately, they consider breast self-examination value to be limited. Let's see the perceptions of the participants. All participants reported that doing screening tests would help them with early prevention and early intervention of breast cancer. What about the beliefs about the possibility to become ill from breast cancer? Participants, most of the participants, felt that they are not particularly at risk of being diagnosed with breast cancer. Their attitude toward breast cancer, most participants are frightened concerning the issue of breast cancer, but this fear is translated into different preventive modalities. Some of them show an attitude of avoidance. Some others do not perceive themselves at risk, or they have an attitude carrying out strictly necessary practices. And finally, the attitude toward mammography screening and breast self-examination. Unfortunately, as I said before, participants avoid breast self-examination, devaluing its benefits and trusting that their health is well. Also, participants referred fear for the examination procedure. And we continue with the results of focus group, and we move on the motivational factors that influence preventive practices. I will focus on the common findings from the 2 groups. The first finding that motivate the person, the carer, to act preventive practices is the perceived responsibility toward her own family to take care, and second, the experiences of close people who died from cancer. Also, informal carers mentioned the fear of the disease as well as a motivational factor. And we continue with the barrier factors that influence preventive practices. Here, I would like to draw your attention to the common points that both groups mention. Firstly, the lack of time of the carer and the responsibilities to the person they care and their own family is one barrier factor to act preventive practices. Another barrier factor is the fear of being diagnosed with breast cancer and the fear of getting sick and the fear of dying from cancer. And the third barrier factor is the lack of knowledge and skills to perform breast self-examination. Also, I would like to mention that informal carers mention as a barrier the fear and the feeling of guilt in dedicating time for themselves. And of course, difficulties going to the hospital due to the caregiving duties. And finally, the last question about what should be included in the breast cancer educational program in order to motivate informal carers to adopt breast cancer prevention behaviors. Both groups, caregivers and health professionals, suggested that it's very important to convince informal carers that prevention saves lives and to motivate them to do their screening tests and breast self-examination regularly. Also, they suggest to encourage carers to dedicate time for themselves, adopting a healthy and consistent lifestyle, to empower them to changing lifestyle, to add physical exercise in their program, healthy diet, losing weight, to provide information on primary prevention of breast cancer and information on breast cancer disease and its treatment in order to manage the fear of cancer disease. Activity suggestion and exemplification at the non-advanced but accessible level. Motivational factors for adherence to preventive behaviors against breast cancer, and of course, to motivate carers to use technology to promote preventative behaviors. And now, let's turn to the second intellectual output. This intellectual output includes the development of the training contents, which will be included into the app, such as suggestions for activities to be performed in class. Here, I would like to emphasize that, and going back to the intellectual output one, the preparation of this program, the training program, was based on our findings of the focus groups. The training material, built through the collaboration of different professionals, including university academics, nutritionists, psychologists, nurses, and personal trainers, aims to stimulate the adoption of positive health behaviors for carers. In details, the training focused on the following topics. First, relevant knowledge about breast cancer, prevention through physical well-being and psychological well-being, prevention through early detection, and self-efficacy and management of the caregiving role. The material developed will be pilot tested with the participation of women caregivers in Cyprus, Italy, and Portugal. These women will have the opportunity to download prior to the general public the Prolipsis application and participate in 4 free training sessions in presence. In addition, participants will be guided in the use of the app to understand its full features and potentials. The material used during the training will thus be accessible to them from the application and will then, at the end of the pilot, be made available to the general public. Through the Prolipsis app, participants will be able to access the training material, videos, and articles on breast health and preventive lifestyles. The course will take place in the partner countries and will be led by the project coordinator, Cyprus University of Technology in Limassol, and by the partners Anziani Non Sole in Italy and Portuguese in Portugal. In each country, 10 caregivers interested in undertaking this health promotion course will be involved in a totally free way. The course is characterized by 4 online virtual autonomous lessons through the Prolipsis app, downloadable on Android and iOS devices, and 4 sessions in presence of approximately 1.5 each, or online through simultaneous training platform such as Zoom, in case COVID-19 restrictions do not allow it to be done in presence. And let's move to the intellectual output 3. This intellectual output includes the development of a personalized mobile application, which will support informal carers to better manage self-care and behavior change in illness prevention. A prototype of the application designed by Singular Logic and its functionality tested against the specification derived and also tested its content and usability level by all parties. Full development of the application and integration of the components in English is ready. The developed application tested by one representative of each partner organization and fine-tuning implemented. Usability testing will be performed through the pilot testing, as we said before, with a sample of end users. And here we can see what the application offers. What are the features of this application? First, the profiling and personalized content. In the first interaction, the user will be presented with a personalization wizard. The user will be required to input a unique username, her region, as well as her year of birth, and then will be presented with a series of questions to build her unique profile. These questions will include, for example, comorbidity questions, history of breast cancer questions, and hereditary factors in her family questions. Of course, the tracking features, for example, tracks physical activities of the users and send notification and encourage and provide positive feedback to him, to her. And of course, information and material and tutorials will be available in this application, presenting the pedagogical and relevant information material and the educational videos that already prepared in the intellectual output 2 in the training program. And of course, a friend network will be available. It will enhance connection among people in common situations through a specific forum, and the limited group of friends will be involved and will empower each other to do the breast self-examination and other screening tests. Also, in this application, it's keeping track of her monthly breast self-examination and mammography test according to her menstrual cycle, and of course according to her profile as well. Here we can see the chat with close friends, and each other empower each other to do their screening examination and breast self-examination as well. We can see here the administration console, the platform, and it's very important to mention that the app is in pair with a simple administration console. There, the app administrator will be able to put country-specific content for the app users. Here we can see the risk level of each user based on the answer the users provided at the beginning of the entrance in the application, and the international guidelines for breast cancer screening. The user will be categorized according to the breast cancer risk in order to will be categorized in the low risk or medium or high risk, as we see in our slide, according to the breast cancer risk in order to receive personalized content and appropriate notification in order to do her breast self-examination and mammography or clinical examination screening test. Of course, based on each user's profile. Here are the list of articles that the administrator will upload on the platform and the user can read from the application. And finally, we're closing with the intellectual output 4. It's a handbook for educators, and it can help a user how to use the app in the Health Literacy Informal program. The handbook will be in an ebook containing practical suggestions, guidelines for the 2 different target groups, which will be based on the lessons learned through the previous project activities that we already mentioned. This output, it's on now it's beginning. It's on progress. Here we can see the partnership, the 5 countries that are involved in this Erasmus Plus project. In Cyprus, the Cyprus University of Technology and Eurovadona. From Italy, Anziani Non Solo. From Portugal, Horticarers, and Greece, the Singular Logic company. And of course, if you want to learn more about the project, visit the website and click on this link. The website is open access, and it is the best way to keep in contact with the partnership and to keep update on project activities. Thanks a lot.
Thank you very much for having me here at this wonderful conference. These are my disclosures. I am receiving institutional funding to implement symptom monitoring for lung cancer and renal cell cancer in the Netherlands. And before I will take you more into depth of utilizing technology to manage symptoms, I will shortly show what we are doing at IKNL in the Netherlands. And at IKNL, we use the profiles infrastructure to measure PROMs in cohorts of cancer patients, including symptoms. And this data are linked to the population-based cancer registry. So we have an app for symptom monitoring using the ProC2C AE score that is displayed in this screen. And the ProC2C AE is translated and validated in many languages worldwide and is mapped with the CTC AE. And this means that patient-reported symptom scores are converted to toxicity grades of the CTC AE, which in turn determine the necessary interventions according to clinical guidelines. The ProC2C AE consists of questions regarding frequency, severity, and/or interference of a symptom. So it's not only about the presence, but also about the burden of the symptoms for the patient, which is of course also very important for the decision whether or not to intervene. At first login, the patients provide informed consent to use the data for scientific research and to share the data with the healthcare providers. Then patients receive information about symptoms and they are asked to fill out a diary at least once a week. And if a symptom exceeds a particular threshold, the patient receives an alert, the advice to contact the hospital. And this alert is also forwarded to the hospital. And the alerts are firstly based on the sum scores of the ProC2C AE as defined by Ethan Bash and his group. And together with nurses, we have set up cutoff scores for the alerts. And in addition to the about 70 symptoms of the ProC2C AE, we have added 50 additional symptoms. So we defined decision rules for about 120 symptoms in our system. And for example, if there is a yes on threatening symptoms like fever or coughing blood, there is an alert, or for other symptoms like weight loss, it is set for 3 kilogram loss over 2 weeks. And for many other symptoms, the rule is grade 3 or an increase of 2 grades within 2 weeks. We now use 8 different algorithms for alerts behind the scenes at IKNL. And after filling out the questionnaires, the patients received an overview of the symptoms over time. And this overview is also sent to the hospital. And then the nurse can start symptom management, and the physician can decide about dose reduction or co-medication to reduce symptoms. And this is an example of the overview over time, which is also helpful to use during consultations, as you might detect trends. And in this example, you can see the orange line for neuropathy. That is low during each consultation visit, during which lab and tox is checked, but is increasingly high after each additional cycle. You can imagine that this symptom could be overlooked in daily practice, and based on this figure, for this patient in our pilot, the dose has been reduced following cycle 6 to prevent chronic neuropathy. And overall, the main goal of symptom monitoring is early intervention, and to prevent symptoms from worsening and maybe also diminish the symptoms that are still present for many years following treatment against cancer. And that's also why the title of this slide says, during the whole patient journey. In our profiles infrastructure, we monitoring symptoms from diagnosis until follow-up, and also including the palliative phase. One of the nurses that uses symptom monitoring as one of the first Dutch hospitals said that she uses her time with the patient differently. So I asked why, and this is what she answered. It takes more time upfront to explain the app and motivate the patient to use it, and your colleagues too. Once the patient has completed the app, you can see at a glance where the problems are and at what point in time this is happening. So the interventions can be more targeted, and it is also more transparent for the patient why you suggest certain interventions. I will come back to implementation and lessons learned later in this presentation. So now we have seen the general idea behind symptom monitoring. Let's dive somewhat deeper into utilizing technology to manage symptoms. In Andrea's book, Wendy, Doris, and I wrote a chapter about symptom monitoring. And we saw that there's already quite some work done in this field, and there are several potential features to add to symptom monitoring. A rapid review of the literature showed 35 papers describing web-based applications for or apps for mobile devices. Most papers were from Europe and North America, so it seems that's not that much used yet in Asian countries. Most studies were randomized trials and feasibility studies, and most papers described symptom monitoring during treatment, of whom 63 during systemic treatment and only 8 also monitored during follow-up. Most apps reported to monitor symptoms, and this varied from one specific symptom like pain to many symptoms in a row. Half of the apps included a type of education, and a minority also had an e-consult function or an alert function or advice to enhance self-management. And the most commonly questionnaires are the ProCTC AE and the Memorial or Edmonton Symptom Assessment Skills. Using apps for symptom management has started several years ago already, when a trial showed that symptom monitoring led to a better health-related quality of life and survival, less admissions to the hospital, higher medication adherence, and less visits to the emergency room. And this is the work of Ethan Bash in his group in the US. We can roughly subdivide the process of symptom management into 3 sections. First, the symptoms need to be identified through the patient, and that is where a monitoring app comes in. Thereafter, you as a nurse can perform triage to come to a diagnosis and decide about an intervention. And the patient can, however, also be instructed to do self-management against the symptoms. And whether the intervention was successful is seen again in the identification, whether or not a symptom remains present when the patient fills out the questionnaire in the monitoring app again, or when the patient has a consultation visit, of course. And just to give you an idea about development of technological features, I will give you some examples. And one application for identification of how the patient is doing at home is LifeLight. And the LifeLight application remotely measures vital signs with a technique using light absorption or reflection to measure blood flow within the superficial blood vessels of the facial skin. And this app can be used on any smart device. Then the LifeLight operator takes about 40 seconds video of the patient's face, the data is transmitted to a cloud, then the data is analyzed using artificial intelligence algorithms in the cloud, and then the results are transmitted to the smart device again. And this application has been validated in a large group of patients and was used for cancer patients in the small feasibility study to measure vital signs in palliative care. So it's a sophisticated, a really low-key measure that hardly requires tasks or input from the patient. And this is only one example of the many so-called passive data collection methods. And if you want to measure symptoms or vital functions to monitoring the patient's health at home. But there are so many more, like on the left-hand side, the Australian Virtual Hospital, or a bio sticker measuring, amongst others, heart rate or glucose levels, or the more commonly used activity trackers and smartwatches, and hubs to easily answer questions to preset questionnaires. And these are not only used in research, but will become more and more standard care. And this is not only about symptom monitoring, but all kinds of biological and chemical reactions. For symptom monitoring and identification, add-on to the app is, for example, to make pictures of dermatological symptoms that are forwarded to the hospital, which is again the active monitoring, as the patient has to report. And then back to symptom monitoring. After identifying the symptoms that introduce a health risk or are bothersome to the patient, the nurse performs triage to come to a diagnosis. You might all know the EONS triage tool, providing advice about green grades that involve self-care advice. The amber ones need to be reviewed within 24 hours, and the red ones that need to be assessed as soon as possible. But this tool is only focusing on single complaints, but the symptoms, of course, often occur in combination. So if there is diarrhea, it might not introduce a severe health risk, but in combination with other complaints like abdominal pain or dehydration, action should be undertaken to prevent admission to the hospital. And there are digital algorithms for alerts using multiple symptoms in the so-called advanced symptom monitoring and management system. And you might understand that these are much more complex, multi-layered alerting algorithms with multiple pathways. And also, this system uses alerts graded red and amber, indicated the preferred healthcare professional response time. And in the Canadian version of the symptom system, there are also triage questions added automatically, so without prior interposition of a nurse. And you can imagine that it saves time if you have all or most of the triage information available already. So you can set the diagnosis and discuss in the team also the probable interventions already before contacting the patient. So this is also how technology can help to save time in the ward. And if there is a diagnosis, the next decision is about intervention. This can be dose reduction, co-medication, or termination of treatment. And termination of treatment is, of course, the fear of many patients and a reason to underreport the severity of symptoms in person or when using an app. And patients reported in our pilot study at IKNL that they considered the symptom monitoring app to enhance communication with a healthcare professional. And they thought it was easier to report particular symptoms online than in face-to-face conversations. And this might not directly have to do with the severity of the symptoms, but certainly with the symptoms they felt ashamed about. Once already reported online, it was easier to bring it on during consultation. And another intervention is referral to, for example, a dietitian or a dermatologist. One thing we are about to start in the Netherlands is using the symptom monitoring to more timely detect immunotherapy-induced skin toxicity. And dermatologists and oncologists aim to introduce early referral, so preventing escalations like shown on these pictures that significantly influence the quality of life of our cancer patients. And the monitoring app is to be implemented in the internal care pathways for referral, which is also a use of technology to improve symptom management. And then there is also the self-management, which is one of the main topics of research of our colleague Manuela. And she has developed a Symptom Navy program. This is a nurse-led intervention supporting patients' symptom self-management during treatment. And it consists of patient information, semi-structured consultations, and a training manual for nurses. And self-management is an ongoing process as the patients need to have sufficient knowledge, adequate skills, and also effective confidence to achieve attainable goals. And very important in these is self-management behavior, in which perceived self-efficacy is key. And you can find the information about this program on PubMed. Likewise, adding online triage questions following a particular answer to symptom severity or burden, you can, of course, also automatically advise patients to use self-management apps or other interventions. And digital health is also used in self-management apps to improve or live with a particular degree of symptoms or complaints or disabling factors. And our colleague Sangeeta Agarwal from the US is an expert on the field of wonderful innovations. And during the MAS conference, she presented last year, amongst others, these two interventions. One app guiding patients in an exercise program tailored on a specific physical condition and complaints, or a robot who helps the patients with tasks throughout the day that are less able to complete if they are less able to complete them by themselves. And also here, self-management behavior and self-efficacy are important. And then following intervention, we are back at the identification, and that is evaluating whether the intervention was successful, as can be displayed again by a monitoring app. And now shortly back to the symptom monitoring, as its added value is highly dependent on the implementation. And as the details in the workflow differ between cancer center services, tailored implementation strategies should be designed based on the researches of each separate clinic. And if you are about to start symptom monitoring, there are implementation frameworks available, for example, from ESOCOL or from Cancer Care Ontario. And for symptom monitoring specifically, the EPHOC intervention has been developed. And symptom and self-management implementation is included in the chemo support intervention. And the chemo support intervention applies motivational interviewing and goal-directed self-management coaching. And these implementation methods toolkits are available online, so I won't discuss them in depth, but overall there are 3 key themes for implementation, that is acceptability, outcomes, and sustainability. And acceptability incorporates patient and healthcare providers' perspectives, as well as the clinic as a whole. And you really need to engage all stakeholders and appoint a clinic protagonist for each hospital. And these are key for successful implementation. Then the outcomes need to be defined and evaluated, through which the added value will become clear. And here you also need to build healthcare provider capacity and confidence in interpretation and responding to the symptom data. And sustainability is about the technology that needs to work well, but also the long-term use of the technology in daily care, as implementation costs quite some time. Is helpful if, for example, a clinic can proceed using monitoring apps after the research project has been terminated. And a few most important lessons learned are with respect to the implementation, and I would like to share them here. The relevance of the questions is most important for the patients to be compliant in using the app, and therefore it's helpful to take a look at the content and frequency of the questionnaires. And that might differ from the treatment phase, in which many fluctuations in symptoms might occur, versus the phase of follow-up or during watchful waiting. But it might also differ for the phase of palliative care or end-of-life care. And algorithms can help here too, that a patient automatically receives an additional questionnaire if there are high scores on a particular issue. So really try to make the content and frequency tailored for a patient, as it is not one size fits all. And then compliance in the nursing team. Symptom monitoring is primarily meant to reduce health risk. So the algorithm behind, at least the ones that are forwarded to the healthcare practitioners, should be first sensitive enough to detect risk, but at the other hand also prevent from an overload of alerts. That overload of alerts, that can be the symptoms that can wait until a next consultation. So if a patient scores a high grade of, for example, depressive feelings, in my opinion, this should not immediately introduce an alert to the hospital. You can also add, for example, self-management intervention. All the alerts and the algorithms behind it is really work in progress, which will be refined in the forthcoming years. Furthermore, linkage with the electronic health record is crucial to use the outcomes on the computer during consultation. And that is in turn the main incentive for patients to adhere to symptom reported. That the nurse or the physician takes a look at the figure of how the patient has been doing at home, and they don't have to report it over again once they are in the hospital. And last, practical advice, and that is on the instructions to the patient. I told you before that fever and cough and blood are included in our app, and that is immediately produces an alert. However, the digital symptom monitoring is in addition to standard care. So patients should be instructed not to use an app in case of a potential life-threatening symptom or in case of doubt. They then really need to make a phone call. So such an app is not about checking whether something is wrong. It's about more timely detection, prevention of severe symptoms, prevention of worsening. And this needs to be very clear to the patient. And besides the use of online collected information about symptoms in daily practice, which is most important for the patient, you all know about the rapid developments in treatment options. And it takes way too much time to study all the sequences of different therapies in trials. So therefore, I'm so happy that many nurses are research-minded too. And if data that are collected in daily care and shared, we can also gain knowledge about new treatments with their new toxicities, but also their old toxicities to get an overview and in order to develop supportive care interventions. And in the digital world, so many data are collected, so let's use them for the common good. And that is called the secondary use of data. And that is because there are so many questions to further improve symptom management, because who is developing the symptoms and why? And what are the underlying pathways? And what's the relation between symptoms during treatment and the long-term and late effects, and how to address them? So if you are collecting symptom data already or about to start, don't forget about the data plan and the science behind it. So in conclusion, technologies are used already in symptom management to identify the symptoms for diagnosis and intervention on symptoms. And we have seen that the apps can help to capture data actively reported by the patient or passively if the patient only has to wear a device. And technologies can be used in all phases of disease and during or following all cancer treatments or during watchful waiting. And there's much knowledge available already, so use this information and don't start over again. And this is not only about the content of the app and the algorithm behind it, but also about the implementation. Many papers are already there guiding you when you want to start symptom monitoring or using technologies. Well, these technologies are often simple to use, and once on the market also low-cost solutions. And the apps add to the outcomes for the patient, as symptoms are one of the most important aspects for the patient's health-related quality of life. And the app also adds to cost during cancer treatment, as they prevent hospital admissions and emergency room visits. The cost is also about time. And by using the app, the symptoms don't need to be captured during regular consultation anymore. And in case of ad hoc occurrence of severe symptoms, triage can also be performed online beforehand. But time is also about quality of care and about personal time of your nurse. And I think that we can use technologies to manage symptoms in a personalized way, that in the future, the nurse can choose what tool fits the particular patient best and use the technology to save time if helpful. and then with the result that the nurse is able to spend time to provide personal care if needed. Thank you very much.
Presentations who gave an insightful view on the experiences, the lessons learned about utilizing technological solutions for cancer care and in specific e-health and mobile applications. At this point, I would like to remind our audience that they have the opportunity and the ability to send specific questions to our presenters. So these can be answered and discussed through this live discussion session. I would like to open the discussion with a question that came earlier, and it was addressed to Theologia. The question, Theologia, for you was how can mobile applications promote healthy behaviors when it comes to patients or informal caregivers within the context of breast cancer prevention?
Yes, I already answered, Andreas. It was actually a two-part question. Regarding the first part, okay, the encouragement of the use of a mobile app to use the technology actually for female informal carers would help them to maintain active control over preventive behaviors by reminding them, by making them alert, sending personal notifications to regularly actually utilize preventive practices such as breast self-examination every month and the mammography annually. Additionally, it promotes self-monitoring of their health. For the second part of the question, it was focused on the challenges that we faced during our piloting last month regarding the people that can can't own smartphones, or they don't have a connection, internet connection. So we try to solve this problem, preparing an educational program regarding the breast cancer and breast cancer preventive practices in order to enrich their knowledge and help them to understand how what they are going to do, and to remind them not to forget and to take care of themselves. This was the second part, I think. Yes. I think there is another question, Andreas.
It's okay. It's okay, Theologia. We can come back to the third scale of that question. There is another question which is basically addressed to all of you. The audience is interested to know how can we implement nurse-led interventions based on data we collect through, for example, mobile applications, through web-based applications, or other technological solutions. So perhaps, Manuela, would you like to start the discussion?
Well, I will start, and my colleagues will certainly be able to complete this. But I think what we should do is definitely collect a lot of data, not only on the symptom itself, but also, as Corinna has showed so nicely, the electronic applications allow us to profile the evolution of the symptoms over time, and we should also monitor the interventions that were provided, for instance, self-management support, but also non-pharmacological and pharmacological interventions that were provided that then could probably guide us towards the need for the development of new interventions, and also how we could reinforce them. That would be rather a measurement part. And on the other hand, I think we should always, if we do research or if we implement these tools in practice, we should gather data about the implementation process. So we should also interview patients in open-ended interviews, or question them what would they need to be enabled to better manage their symptoms, and include this in the development of new nursing interventions. That would be my most prominent recommendations.
And Corina, anything to add your end?
Yes, I totally agree, Manuela, what you're saying. And I would like to add that indeed also for research purposes with the aggregated data, you can also perform analysis and have mirroring information about how the patient is personally doing and what the general cancer patient with, for example, the same age and the same type of disease, the stage of disease, how they are doing. So then you can also use it, for example, for making decisions about interventions and supportive care. So that's also something that you use the data for to nurse-led interventions.
Thank you both. I think that makes it crystal clear on what the way forward is. All of you mentioned various technological solutions, and there is a question in the Q&A in terms of what kind or what types of applications are in the pipeline on being released in relation to patient-reported outcomes and symptom management. I mean, the ones you already know, and should our audience be keeping an eye out for, if you know any applications in that sense. I mean, except the Prolipsis, which is in the testing phase and will be soon released on Google Play and also on iOS. Corina and Manuela?
Yes, there are so many apps in the pipeline, of course. It's going crazy, I would say. But there is the difference between what is developed in projects and what is already publicly available. So then we also have to do with accessibility of patients, but also nurses and physicians to those apps. And most of the work for symptom monitoring, at least, has been done in the US by the group of Ethan Bash. And in Canada also, Doris Howell is involved in large projects using the Edmondson symptom assessment scales, and they have all kind of algorithms behind it. And also in the UK, there is a group very active, and also for the symptom monitoring, at least. Then there's the next hurdle to take, is indeed to make it more openly available. So that's a challenge that we all have to address here, I think. And then again, that's also very important that we don't all reinvent the wheel, that we, with people who are now active in the field, try to work together, get connected to each other, and that we share at least the information. So if it is not publicly available, that you can at least also develop it for your own professional organization. For example, if an organization like EONS or MASK or such larger groups make such an app, then it is very much easier to get it accessible for the common good. Yeah.
So maybe to complete Corinna's, I mean, we also have excellent projects in Australia. We have, I mean, in many countries, there are many different applications that are developed. I think we cannot recommend one of them because there is no gold standard at the moment. The question that every nurse should always get an answer to is, how was the tool developed and how do they guarantee that what is measured is valid and reliable? So, because I mean, we have many years of experience in the development and implementation of patient-reported outcome measures. And now with the application, we sometimes are confronted with situations where it's rather technology-driven, but not content-driven. But we should not ignore all the knowledge that we already have about validity and reliability of prompts. And this should be the first question. And so is this really, you know, the questions that patients answer, are they really tailored and targeted to this particular population? And has this been tested to be really, to provide valid and reliable answers? The other question is, say, the safety of the data. So who is owning the data and who is doing what with this data at the end? That, I think, is a very important other question that always should be raised. How can you make sure that these data are really stored and used under all the ethical principles? And I mean, I showed this related to the artificial intelligence, but we have, as healthcare providers, we have to be very vigilant to not expose our patients to any application that would put the data safety at risk.
Thank you. Thank you all. There is also another question on the same issue about collecting data and applying those data. For example, what would be your view in using these digital solutions and artificial intelligence, not in clinical care, but also in the management of clinical trials in oncology, drug discovery, novel biomarker identification, etc.? I think this is already a reality at the point. It's maybe not so well advanced, but definitely there should be some areas for these solutions to offer something. What would be your view on this? Either of you can answer the question.
I mean, regarding artificial intelligence, we see already that this is applied in the accumulation of data that is gathered. So we have big data sets already where this is used in clinical trials to be able to predict, for instance, certain symptoms. For other technological solutions, I would not be able to just give you a concrete example at the moment, but of course, I mean, all the examples that I've shown in clinical practice also apply for clinical trials, and I mean the examples that I showed regarding pain management, this was clinical trials. It was tested still. So I hope this gives an answer to the question.
Yes,
thank you, Manuela. Corinna, please.
Yes, to use AI, you need really large data sets. So that's the first thing that's there. So if you have, mostly the trials are quite small. And there is something for the future again. If we use the same methodology and use the same codings behind it, then we can easily share our data to perform AI. And then, for example, for symptom management, you can use it also maybe to see the profile of a particular patient and also the symptoms that were reported during chemotherapy, for example. And then you can predict the follow-up schedule for that patient, for example. Is this a high-risk patient to have complications and long-term effects or not, and how often do we need to see the patient in the follow-up time indeed? And during the treatment, you can also, like Manuela already says, predict if you have maybe 2 cycles of chemotherapy and there were a particular pattern of symptoms, that you can predict how this patient will be doing at cycle 6. So then you can maybe already do dose reduction at cycle 3 to prevent worse symptoms at cycle 6. So that's what huge amounts of data can do in daily clinical care. Yeah, but much research is needed there. Yeah.
Thank you, Corina. This is a more general question. It is addressed to all of you. In your presentations, you mentioned health literacy, patient co-creation of these technological solutions throughout development and implementation. My question is, or I would like to hear your views on delivering truly person-centered solutions, because what we have seen in the process, the actual person gets lost, for example, in those big data. So is it feasible to deliver truly person-centered technological solutions, in your opinion?
Well,
Marina, you go first.
Yes, I would say what I see for the future is, as there isn't one size fits all for individual care, that maybe in the future on your dashboard in your electronic health record, that you can select particular apps or interventions, etc., for a particular patient. So that might be no e-health at all, or it might be that you do symptom monitoring, but not on a weekly basis because that's much too intensive for that patient. So you can set that it is once a month, for example, so that you can make it more patient-tailored in that way.
Thank you. Anything to add, Manuela?
Well, I think this is one of the maybe the most important reason why nurses should contribute to the innovations in this field, and also why we should really investigate in PPI, that is also discussed at this conference, so public and patient involvement, that this is not only driven by our interest in developing technologies, but to really provide the best support to our patients. And I think that we have opportunities to really improve care, but it needs to be thought through. And this means that we have to really share all the perspectives and put all the minds together. And this is, I mean, also when we were discussing about interprofessional collaboration and interdisciplinarity, 10 years ago, we were thinking about the nurse and the physician working together. And today, I mean, the engineers, the IT people need to sit at the table, but equally, the patients and the relatives need to sit at the table as well.
Thank you, Manuela. Thank you. Unfortunately,
Andrea, regarding that question, sorry, I was thinking of the Prolipsis app, actually, that is, we try to personalize that application for for each person that use this application. So it puts all, I think the, how may I say, the characteristics of the person. So it's like becoming a personalized. We try to do this in the prevention part, not in the symptom management. I don't know if you agree to that.
Of course. Thank you. Of course, we agree. And personalization can happen at any point of the patient's journey, from development and throughout the disease. So yes, we do agree. And unfortunately, this is all the time we have for this Q&A live discussion. I would like again to thank personally Manuela, Corina, and Teologia for your insightful views on this emerging topic within healthcare. Definitely, with your experience, you demonstrated what the way forward is and what the opportunities are for nurses and other healthcare professionals to engage in such technological solutions to the best interest of both the patients and the healthcare professionals. Thank you, and for you online, please stay tuned for the rest sessions of EONS14 conference. Thank you all.
Thank you, Andreas. Thank you very much.
Thank you very much.